I'd like to thank you for the opportunity to give this presentation today. I'm Sakura Onozuka, a first-year master student in Graduate School of Medicine in Kyoto University. I'd like to talk about development of prediction model for optimal treatment selection in cancer therapy using genetic testing data. Now let's get started by talking about background. First, I'd like to talk about cancer genomic medicine. Cancer genomic medicine is a personalized medical care based on a comprehensive analysis of genetic mutation in cancerous tissues. Here is the basic flow of cancer genomic medicine in Japan. Since 2019, cancer gene panel test has been covered by insurance in Japan. When patient takes a panel test, the result, along with clinical information, is shared with expert panel and they choose the best treatment plan. Now let me touch on the method of treatment selection. In expert panel, the candidates for the treatment are basically the drugs that are effective for each genomic mutation. However, even if a drug considered effective for specific mutation, its actual effectiveness varies from person to person. Here's the example. The data shows that out of 18 patients with AGFR exon 80 mutations, only 34% good response with EGFR TKIs, which is an effective drug for this mutation. As you can see, it is difficult to predict the response only a single biomarker. Therefore, it is necessary to predict treatment response by considering multiple genetic mutations and personal background data. Accordingly, we will focus on using machine learning methods. Several studies have been conducted on predicting treatment response using machine learning. From here, I will introduce some of them. Here is a diagram on basic flow of these studies. There is a cancer patient, and a certain treatment is administered to him. Some response will appear. Here, we use machine learning to predict these responses. Here are two previous studies. For example, in the first study, they predict the response of ARSI, androgen receptor signaling inhibitor. Some of the data used for the prediction are WTS for transcriptome sequencing data and WGS for genome sequencing data. I have introduced some previous studies so far, but we do not think these studies have sufficient clinical utility because previous studies have focused only on predicting the response of particular treatment and used clinically difficult to obtain data. Considering these limitations, we developed a machine learning with high clinical utility that can be applied in cases of various treatments using data that can be obtained in actual clinical practice. Furthermore, while the number of analyzed cases in previous studies was around a few hundred, this research conducted a large-scale study using data from over 20,000 patients. Now, I will talk about the objective of this study. In this study, we named developing a machine learning model for predicting treatment response for each regimen. In this study, a regimen means a group of drugs prescribed in the same period. Please note that the number of drugs per regimen can vary from 1 to multiple. As background information about patient, we used basic information such as age, treatment history, and genetic mutation, and TMB. TMB is a metric that indicates the number of mutations per million base pairs. Also, it is often treated like a biomarker. For example, if TMB is high, immune checkpoint inhibitors tend to be effective. Next, I will explain the data used in this prediction. We utilize data from CCAT. CCAT is an organization that collects, stores, and utilizes data derived from cancer gene panel tests and clinical information in Japan. Therefore, it is a kind of real-world data. This data consists of two parts. One is the cancer gene panel test data. This includes data on TMB and genetic mutations shown by the panel tests. The other is clinical information. This includes data on treatment which is administered to a patient and its response. Please note that there are multiple data entries for each patient. We created a dataset by combining these data. Now, let's discuss the dataset. The table below is the overview of it. The response variable in this study is the response regimen. In a second, the treatment responses are classified into 4 categories according to RECIST criteria. In this study, we defined PD, which shows no treatment effect, as poor response, while other 3 categories were classified into good response. With this label, we created a binary classification model. On the other hand, the explanatory variable includes the data on one hot encoded resume information and patient background information. It is possible to predict the response of over 400 different regimens with a single model. As mentioned earlier, there are approximately 20,000 patient data, but due to the combination with different regimens, the total data count is about 15,000. And for the model architecture, we utilized random forest, and evaluation was conducted using five-fold cross-validation. Now let me talk about the results. Firstly, in addition to the model that used all features discussed so far, we constructed a model that did not use treatment history or genetic mutation and compared it with other models. By doing it, we investigated which type of feature contribute to the performance. The accuracy of 3 models is illustrated in this graph. Considering the 4 evaluation metrics comprehensively, the model using all features, red graphs, show the best performance. Therefore, the performance improved by adding genetic mutations and treatment history data. However, in terms of recall, the model without treatment history, yellow graph, show the best performance. Since the number of cases with the same treatment history being limited, the treatment history data may not be so effective. Next, to investigate which features contribute to the performance better, we computed feature importance. The graphs show the top 6 of it. The top 2 factors are age and TMB. These factors are also regarded to affect treatment response in previous studies. Therefore, the prediction can be considered reasonable. Additionally, the 5th feature, BRCA2, is known as a biomarker for breast and prostate cancer, while the 6th feature, KRAS, is recognized as a biomarker for lung cancer. Next, I will discuss the prediction accuracy for each cancer type. The graph shows the ROC-AUC for each cancer type with a prediction made by the same model. The vertical axis shows the cancer types, while the horizontal axis shows ROC-AUC values. Additionally, the colored dot indicates the ratio of positive to negative data points for each patient. As you can see, the difficulty of prediction varies by cancer types. And looking at the top 2 cancer types, they have a significantly higher proportion of positive data points, and it may be one of the reasons for their higher accuracy. Next, examining the cancer types ranked higher, we can see prostate, breast, and lung cancers. As mentioned in previous slide, the existence of effective biomarkers could contribute to their high accuracy. Now, I'd like to conclude my talk. In this study, we developed a machine learning model with high clinical utility for treatment response prediction using data that is obtained in actual clinical settings and that can be applied in cases of various treatments. And future work is in this slide. By creating this model, we can get data on how different regimens are expected to work for each patient. Therefore, in the future, we believe that these prediction results can be used in expert panel, contributing to the realization of more comprehensive and informed treatment choices. Thank you for your attention.
Thank you for your talk. Any questions or comments?
I saw you had a point about doing it on external data sets. Have you thought about what you might use for that? Something like the Civic database, or there's a lot of really good resources out there now that link genetic information to prognosis in cancer. And I think it would be really valuable to expand it beyond your initial set you're looking at and see if it's generalizable.
Oh, thank you.
Any other questions?
Thank you for your talk. I'm interested in your reason why you used the random forest model. Is it as a better performance or
Okay.
another reason?
Thank you. Okay, I have the data about it. Yes, I have tried not only random forest, but also XGBoost and YGBM. And you can, as you can see, the random forest achieved the best performance. And I also tried neural network, but it didn't work so well. So I decided to use random forest.
Thank you.
Thank you.